Good evening, everybody. Welcome back to Journal Club. I'm Rossella Ruggiero from Rimini Hospital, and today I will host this special edition of Journal Club because we will have two presenters for this session of Journal Club, Dr. Claudio Montalto and Dr. Francesco Costa, that will present the 2 meta-analysis on DAPT in high bleeding risk patients that they published on the European Heart Journal. As expert, we would like to have Dr. Marco Valgimigli. Unfortunately, probably he will not be able because of some issue in cath lab today for our meeting. However, we will have our insight also from Dr. Francesco Costa, which is also an expert on this topic. Before starting, sorry, I don't know if you can see my screen. I would like to start with our poll, the poll that we always send on our social media, in particular on Twitter. And we ask to our audience, which is the minimal duration of DAPT in high bleeding risk in acute coronary syndrome. And as you can see, the main response was for 42% of our responder said 3 months, 38% 1 month, while 6 months and 1 year were less common. So I will ask Dr. Francesco Costa to share the screen, because we would like to learn from you, from your experience.
Thank you so much, and thank you for having me in this very interesting journal club. And so it will be my pleasure today to present the results of a very long effort that took more than 2 years to be completed. That at the end of the day, with Claudio, we decided to split in a project of 2 different population of high bleeding risk patients, so tackling the same problem with 2 different perspectives. So the first meta-analysis that I'm going to talk is about high bleeding risk patients, and especially those that are not treated with a long-term oral anticoagulants that underwent coronary stenting. And our main idea in this meta-analysis was to understand if a very short duration of dual antiplatelet therapy for 3 months or less would be advantageous, would be beneficial compared to the standard treatment, which at that time was 6 months or more. And this is basically the state where we started. So we already know that optimal dual antiplatelet therapy duration is still debated, and probably it will always be. We already know from many years that DAPT is reduced ischemic events, but has a very narrow therapeutic window for bleeding events. And this is especially true in the newly evaluated class of what are they told high bleeding risk patients. So this class of patients that has been let's say discovered, highlighted in the last 5 years, is a very frail population that has an extremely high risk of bleeding complication and still should be treated in a specific manner. So this was our focus that brought us to explore in this meta-analysis the population of patients at high bleeding risk defined according to several standardized bleeding risk classification who underwent coronary stenting. And basically our main idea was to understand if the intervention of 3 months of DAPT or less would be beneficial, would be better than the control of DAPT for 6 months or more. So basically 6 months or 12 months of DAPT, of course, for the outcomes of bleeding and ischemic events that we will see in a minute. To do so, we selected all the randomized clinical studies that tested this kind of treatment to date, which include 11 randomized clinical trials that randomize patients to 3 or 1 month of dual antiplatelet therapy in the abbreviated DAPT arm, or 12 or 6 months of DAPT in the standard DAPT arm. And these are the trials. But most importantly, in order to understand if the treatment is specifically beneficial in high bleeding risk patients, we contacted all the principal investigators of these 11 randomized clinical trials in order to obtain specific data for the patients at high bleeding risk. And this was the definition that was used for standardizing to identify high bleeding risk patients. So the main definition that was used was the precise DAPT score of 25 points or more. Again, the precise DAPT score is a standardized bleeding risk score for patients that underwent coronary stenting, which is based on 5 clinical and laboratory variables, which are age, hemoglobin, renal function, white blood cells, and the history of prior bleeding. A second HBR definition that we also used in order to evaluate in a sensitivity analysis the high bleeding risk population according to a different high bleeding risk definition was the definition according to the HBR-ARC criteria, which of course should be slightly modified because a long-term treatment with oral anticoagulants was not included in this meta-analysis and was excluded for the HBR-ARC criteria. So these are the modified HBR-ARC criteria that has been used for this meta-analysis. And here you can see the outcome definition that has been collected from the various studies. And we did an effort in order to include the more coherent and the more consistent definitions for bleeding in events from the various studies. So the principal outcome that was studied was major or clinically relevant and non-major bleeding, which was defined according to the BARC 2 to 5 criteria, or TIMI major or minor criteria in most of the studies. And the second bleeding definition that was used was major bleeding definition, which in this case was BARC 3 or 5 criteria, or TIMI major or minor bleeding. And again, in order to explore in the most detailed and granular way, we also use 2 different major adverse clinical event definition, which are the MACE-1 definition, which is all-cause death, MI, or stroke, and the MACE-2 definition, which was cardiovascular death, MI, or stroke. So let's go now to see the results of this meta-analysis, which was focused again on more than 9,006 patients at HBR from 11 clinical trials. And as you can see, the pooled results for the 11 randomized clinical trials clearly show that a shorter duration of DAPT, so 1 or 3 months, was associated to a 24% reduction of major or clinically relevant non-major bleeding, and to a 20% reduction of major bleeding in the pooled definition. Exploring the efficacy endpoint with MACE, so in 2 different definitions, we see that there is no excess in major adverse clinical events, neither for the 2 MACE definition used, which was clearly close to the equivalence. All-cause death that was also explored was non-significantly different between the 2 treatments, whereas cardiovascular death was significantly reduced by 21% in the shorter term DAPT arm. So again, in high bleeding risk patients, a shorter treatment of DAPT was associated with a lower cardiovascular death compared to a longer treatment with DAPT. We did also several exercises in exploring the data. This is a landmark analysis exploring only events that occurred after the treatment divergence in the 2 treatment arms. To make a long story short, in randomized trials in which we are testing 3 versus 12 months of DAPT, the first 3 months of the treatment are equal in both treatment arms. So in this landmark analysis, we only explore the events that were occurring in that case after 3 months of DAPT. And the message is pretty much consistent with the overall analysis. Another important subgroup analysis, which was strongly asked by the reviewers and the editors of the European Journal was this one. So a subgroup analysis evaluating the impact of the shorter treatment among the subgroups of patients that were presenting with acute coronary syndrome or chronic coronary syndrome. And again, in this case, we should take a look to these interaction p-values, which are evaluating the inconsistencies between the subgroups. And we can pretty much see that irrespectively of the clinical presentation with acute coronary syndrome or chronic coronary syndrome, we didn't observe a significant interaction, so a significant heterogeneity between these two classes of risk. So thank you very much for your time, and I would leave the stage to Claudio.
So thank you very much, Dr. Francesco Costa. Now, Claudio, over to you.
Okay, can you see my screen now?
Yes, yes, we can.
Okay, thank you very much. So thank you, Francesco, and thank you, Rossella, for hosting this journal club. And also I wish to thank Jonathan and Doree for having us today. I will present our latest research on DAPT duration after PCI in patients with an indication to oral anticoagulant therapy. I'm Claudio Montalto, and I work at Niguarda Hospital in Milano. Again, the clinical question we started from was pretty simple. Francesco already highlighted why it is important. The clinical question is, what is the best DAPT duration in patients with long-term indication to OAC? And I think we can all agree that this is important because OAC patients are intrinsically at higher bleeding risk. And this is the reason why the precise DAPT score, which is one of the two indicators that the current European guidelines suggest to balance bleeding risk, excluded patients with OAC indication. And also for the ARCA bleeding risk definition, having an indication to long-term oral anticoagulation is per se a definition of being at high bleeding risk. So clearly there is a reason to balance DAPT duration in these patients in order to minimize bleeding without compromising ischemic outcomes. But someone could argue that already several trials demonstrated the superiority of a strategy of DOAC plus P212 inhibitor, so really a very short DAPT duration versus VKA and a longer DAPT duration. But these studies design entangled shorter DAPT duration with DOAC type, and therefore it is not possible to ascertain what is the effect size related to OAC, meaning DOAC or VKA, and what is the effect size in terms of bleeding reduction due to DAPT duration. For example, this is one of the most simple trial I'm referring to, which is the ENTRUST-AF, which really tested a strategy of edoxaban plus P212 inhibitor, meaning very short DAPT duration, versus vitamin K antagonist plus DAPT. So in this trial, for example, there was a superiority of edoxaban and a superiority of shorter DAPT duration, but really it was compared to both VKA and a longer DAPT duration. And we know that DOAC themselves are associated with a reduction in bleeding risk compared to VKA. So what is responsible for the reduction of bleeding? The DOAC or the shorter DAPT duration? And this is true for the ENTRUST-AF, but it is true also for the Redual PCI with the Bigetron and also with the Pioneer AF for rivaroxaban. The only notable exception is the Augustus trial, and we will explain it further in detail in a bit. So we performed this meta-analysis, and we included 5 randomized clinical trials and over 7,600 patients that were randomized either to an abbreviated DAPT or to a prolonged DAPT. These are all patients that had an indication to oral anticoagulation and that underwent, and that also had indication to dual antiplatelet therapy. The primary endpoints we analyzed were major bleedings and major or clinically relevant non-major bleedings. And we also explored some safety endpoints. I will mention in this presentation MACE, which was a composite of all-cause death, MI, stroke, and definite or probable stent thrombosis, and on themselves myocardial infarction and stent thrombosis. When these are the 5 randomized trials that we included, we can see that we included the Augustus trial, which is a notable exception to the DOAC trials, because basically because of its double factorial randomization design, it was really possible to ascertain the difference between the effect of DOAC and the effect of shorter DAPT duration. So basically in our short DAPT duration arm included both patients that were randomized to VKA and to apixaban, and in the standard DAPT duration, we included again both patients that had a randomization to DOAC and VKA. We also included the master DAPT trial, but only the patients that were included because that had a long-term indication to oral anticoagulation. And when we analyzed the study population, we can see that it consisted of patients undergoing PCI for stable or for an acute coronary syndrome, and only for the Augustus trial, there were some patients that had an indication to that because of an ACS, but did not undergo PCI. So basically, they were treated conservatively. When we mention abbreviated DAPT in this analysis, we mean regimens that randomize patients to 6 weeks or less DAPT. So there were basically 2 trials that randomized patients to a very procedural DAPT strategy, which were the WOOS trial and the Augustus trial, while the other trials randomized patients to a 6 weeks or a 1 month DAPT. And in terms of prolonged DAPT, we included all regimens that were 3 months or longer. These are the data from the supplementary appendix, but I think they are important to understand which population we are really talking about. And we can see that we did not only have patients that had an indication to oral anticoagulant because of atrial fibrillation, despite they were the vast majority of them, but we also had patients that received the oral anticoagulant therapy because of mechanical valve, because of venous thromboembolism, and for other unspecified reasons, mainly in the master DAPT and in the WOOS and ISO triple trials. With regards to antiplatelet regimens, at discharge, most of the patients received aspirin or clopidogrel, or both, of course, but some patients also received ticagrelor and prasugrel. These were patients mainly from the Augustus trial and the master DAPT trial. And with regards to antiplatelet regimen after DAPT discontinuation, again, mostly they were either aspirin or clopidogrel, but some patients received ticagrelor or prasugrel too. And finally, with regards to OAC regimen, mainly these were patients randomized to warfarin or apixaban, but we also have some patients in the master DAPT trial that received the other anticoagulant, novel anticoagulant, of course. And now to the primary endpoints, we can see that from the data analyzed, we can see that there is a significant reduction in major or clinically relevant bleedings with a relative risk of 0.63, which means about a 40% reduction in major clinical relevant bleeding with a very low number needed to treat of 16. We also proved a significant reduction of major bleedings with a relative risk of 0.7, so basically a 30% reduction in patients that received an abbreviated DAPT regimen. With regards to safety endpoints, there was not an increase in MACE, and there was not an increase in myocardial infarction, neither indefinite or probable stent thrombosis. But some of the reviewers at this point argued that we didn't have enough evidence to really exclude that there was an increase in MACE given the data that we already have with, of course, abbreviated DAPT. Therefore, we performed this analysis that is a trial sequential analysis. It is a complex analysis that, in short, gives us the number of patients in that are needed in a meta-analysis given some a priori data to ascertain a superiority or a futility of a treatment. In this case, to prove a futility, let's say a lack of increase of MACE in our population, we needed 7,000 198 patients, and our meta-analysis with over 7,600 patients really had the power to exclude a significant increase in MACE with the abbreviated DAPT regimen. So we also are pretty safe with the safety endpoints, let's say. We finally performed also a network meta-analysis comparing a peri-procedural DAPT strategy with a short DAPT strategy. So basically, data with the peri-procedural DAPT were from the August and Augustus trial, and all the other trials had a short DAPT of 1 month or 6 weeks. And the results are pretty clear, with peri-procedural DAPT in blue having the highest sucra, so basically the highest chance of reducing major and clinically relevant bleeding and major bleedings, while there is not a winner with regards to MACE, but this is clear because we didn't have a significant reduction or a significant increase of MACE. Still a word of caution on this data, because as we can see in this network, there is not a direct comparison of peri-procedural and short DAPT. This is why we do network meta-analysis, because we can compare arms that are not directly compared in trials, but still all the evidence, all the conclusions that we can take from this data are really based on indirect evidence. So they are really hypothesis generating more than conclusive, I think. And finally, some short take-home messages. This is the first meta-analysis to explore the role of short DAPT regimens independently of what type or indication. Abbreviated DAPT, meaning less than 6 weeks, is associated with a significant reduction in major bleedings and clinically relevant bleedings, but without an increase in ischemic events. And finally, peri-procedural DAPT has the highest probability of being the best treatment for reduction of bleedings without a signal of increased MACE. Thank you all for the attention. Thank you for the great turnout today. And for all of you who wants to read the paper in full, it is now available online in the European Heart Journal, Cardiovascular Pharmacotherapy.
Thank you. Thank you very much, Claudio. Thank you also to Francesco for this great presentation. Really interesting. So, Francesco, I don't know if Professor Margevigli was able to join at the end, but in the meantime, maybe I'll ask to Francesco Costa to give us his insight from his clinical practice on this topic, particularly, and this is my question on that, do you behave the same way? You mentioned the differences between chronic coronary syndrome and acute coronary syndromes in your presentation, but what about differences in STEMI patient and NSTEMI patient? In STEMI patient, we always have the concern about the thrombotic risk more than the bleeding one. Do we have enough evidence to have an answer on this topic also? What do you think?
So this is a very, very important question indeed. So basically, when we talk about acute coronary syndrome, we put in the same pot NSTEMI patients and STEMI patients. And when we know from the experience that these are very different situations. So from the data that so far, there is no clear difference in between ACS, between STEMI and STEMI patients. But we have to consider the fact that most of the STEMI patients that are coming to our attention are generally younger patients compared to the NSTEMI population, which are pretty much older and have a higher probability of being a type bleeding risk. So I think that these probably should be evaluated more in the analysis, maybe also doing a classification in between STEMI patient and STEMI patient. Of course, this is quite problematic because you know that every time that you split the population in more, the numbers will be smaller and the number of tests that you run will be more. So the probability that you get just a chance finding out of your analysis would be higher. So we have to work on getting more data from our analysis, but not torture our data too much in order to give us spurious findings.
And from a practical point of view, which is your practice? How long do you, how much do you prolong your DAPT? in your clinical practice? Do you wait until 1 month? You stop at 1 week after 6 weeks? Practically.
So generally, I personally follow what guidelines say. So I use eye bleeding risk as a gatekeeper. So if the patient is not at eye bleeding risk, so we are allowed to go further in with a dual antiplatelet therapy, or even for prolonged dual therapy. If the patient is at eye bleeding risk at the time of the PCI, so we have to keep that in mind. So there is no reason to decide at the time of PCI the duration of the DAPT, but if you are organizing your center to, let's say, see the patient again in the outpatient clinic at 1 month, that is a great time point to understand if the patient's at eye bleeding risk should be stopped immediately, should be stopped at 3 months, or if should continue with aspirin, for example, or continue with a single antiplatelet therapy with a P2A12 inhibitor. So I think that one way to answer this question is to, so personally, we do see all ACS patients in an outpatient clinic at 1 month after PCI. So in that moment, we decide if we decide to continue dual antiplatelet therapy, with a case being very cautious in eye bleeding risk, or if we stop immediately DAPT at that point. But most of the patients with eye bleeding risk, we tend to stick with a shorter DAPT of 1 to 3 months.
Thank you very much. So if anybody has any question, please type in the chat or ask them live.
Hi, Ross, I have one question. So Francesco, Claudio, hi guys. Congratulations for this work. Nice to see you, and great presentation. So I was just running a bit late. So many congrats for this piece of work. There's obviously a lot of work on duration of bleeding, high bleeding risk patients. My question to both of you is, what's next? What remains the unanswered question or questions that need a definitive answer? Because this is a, let's say, a very busy field with literature, lots of trials, lots of studies. And sometimes it feels like a big web of all sorts of different combinations and configurations. So what do we have to answer as a field?
Hi, Arif. So I'll start answering you with my, let's say, starting from my presentation. So with regards to oral anticoagulant patients, OAC patients, I think there is still some area of uncertainty, because if you look at the most recent guidelines we have, which are the non-STEMI ones, the guideline says that in the famous flowchart of the duration of DAPT and NOAC, they kind of further classify patients in OAC patients, so high bleeding risk patients, in patients at higher bleeding risk, in patients at higher ischemic risk, and in standard patients. So for example, I think that we don't still have in the area of patients with an indication to OAC a clear definition of what might be the characteristics of increased ischemic risk and increased bleeding risk that will, for example, prompt an even shorter and really peri-procedural DAPT with aspirin mainly given only on the day of the PCI at the extreme level, or on the other hand, a triple therapy that will continue up to 1 month, which is what the guidelines suggest, but really they don't have, I think, data to really identify these patients. And so I think in the OAC field that might be something worth looking into.
Yeah, to answer to your question, I think that in the coming years we will see really a lot of research on this topic, and so one of the very interesting line of research that are going that direction is, for example, de-escalation. We are seeing a lot of papers coming out of research regarding the de-escalation of treatment. That could be a de-escalation to from a more potent to a less potent agent, or it also been studied at escalation from a full dose of potent P2A12 inhibitor to a lower dose of potent P2A12 inhibitor. Another thing that is coming out in the next year is to understand, even if in patients that are not treated with OAC, if we really need aspirin immediately after the procedure. And there are studies coming that are enrolling patients in acute coronary syndrome patients that are dropping aspirin immediately after the periprocedural period. So they are continuing with a single potent P2Y12 inhibitor immediately after the periprocedural period. So we are pretty much going in a way of reducing the number and intensity of our treatment that probably is going together with the better devices and the better techniques that we are using, because the modern stents and the modern secondary prevention treatment are reducing the ischemic events. So we are now focusing much more on bleeding.
Thank you.
So if you have any other question, further question, we are almost at time.
So I have a question for Francesco Costa. So you mentioned that not the clinical presentation as a CCS or ACS lead to any difference in your DPT strategy. Is there any procedural factor that can be used for long or just do a standard therapy in high bleeding risk? I mean, a double stent in the left main in high bleeding. What's your strategy? What's your possible duration of that? Thank you.
Yeah, that's a very good question indeed. So I think that we have to split the discussion in 2 points. So what we can extrapolate from the evidence and what we cannot extrapolate from the evidence, because you will never find a randomized clinical trial that is powered enough for answering this specific question. So we have to extrapolate. And in a way, what you are asking, if we should work differently in terms of the duration of DAPT in patients that are undergoing complex PCI, for example, so bifurcation, a CTO, a very long lesion, etc. We did this exercise a couple of years ago in a paper that I published in JAP in 2019. And the interesting finding is that we were not able to see any impact of a longer DAPT duration, any beneficial impact of a longer DAPT duration in high bleeding risk patients, irrespectively of complex PCI. So to make a long story short, if you have a high bleeding risk patients, no matter how complex is the PCI that you are doing, if you give a longer duration of DAPT, you will never have an ischemic benefit, but you only will have more bleeding. In a way, it does make sense. I mean, if you think that duration of dual antiplatelet therapy today is a secondary prevention, so it's not for the stent itself, but is for the protection, vascular protection of the patients. And this treatment has a secondary effect, as side effect that is bleeding. So it is obvious to think that if I'm giving this kind of treatment, of secondary prevention treatment, to a patient that would likely will not stand that treatment, probably I'm giving the wrong treatment. So in that kind of patients, I'm much more sure that other kind of secondary treatment, like, for example, statins or colchicine, that are not associated to a higher bleeding risk do make much more sense. But of course, as I said, I mean, we can only extrapolate the evidence from the data that we have. So again, I think that you will always have to individualize your decision based on the patient that you have in front of you.
And yeah, I want to really add something, since we are mainly interventional cardiologists here. And I think we can also practically do a lot in the cath lab. I mean, we tend to be, I tend to be minimally when we talk about the procedure. So really do the procedure when it is really needed, do stent the least we can stent, and finally also put the stent in very well. So a high rate of use of intravascular imaging. I think that we still don't have data about that, but I think that IVUS guidance on optimal stent implantation will really help in reducing the very rare ischemic event that sometimes we have with shorter DAPT duration. So when I have an high bleeding risk patients and I need to put a stent on the left main, even a 2-stent strategy, I will try to put the stent the best I can, and then I will abbreviate DAPT if clinically needed up to 1 month.
Yeah, absolutely. I mean, the DAPT is there to protect the patient, not to protect a bad procedure. I mean, so the focus here is do the procedure as best as you can, especially if you have an eye bleeding risk patients. Do use IBUS as much as you can in order to optimize your result. And of course, I mean, if you have the choice, just put a single stent instead of a dual stent technique. I mean, if you have the choice.
Thank you very much. A very interesting discussion. All your insights were so thoughtful, amazing, I have to say. So we are running late. I want to thank you both, Francesco and Claudio, for your presentation and for everything you did today with us, you said to us. So thank you very much and see you next time on 17th of March with the next Journal Club.
Thank you, Rossella. Thank you
for having us.
Bye.
Ciao, guys.
Bye.
Ciao, ciao.